Now, for the next session, I'd like to introduce Dr. Joseph Kvedar. He's the director and founder of the Center for Connected Health and has been a friend and a mentor to me for the past 16+ years. Please give Joe a warm welcome.
I'm really excited to talk to you today about personalized prevention. I've been thinking about this topic for a few months, and I really want to share it with you, and I'm eager to get reaction as well. So the words personalized prevention really don't roll off the tongue. We probably should start by unpacking a little bit what we're talking about, because prevention is largely thought of as, well, things like it's time to get your flu shot, or a reminder to have your mammogram, or an anti-smoking campaign. These are population-level concepts. I get the anti-smoking message even though I've never smoked a cigarette in my life, so they're not personalized at all. Effective at a population level, but not at all personalized. Personalization, on the other hand, is never been more exciting and more interesting in history than it is now, because of all of the effort that any number of companies, pick your favorites, whether it be Facebook, Amazon, Google, Apple, Pandora, Netflix, taking data that we leave behind when we're on the internet doing things, mashing it up, applying algorithms to it, and then serving content up to us that is trying to motivate us to buy something. But boy, when they get it right, it feels really special. It feels almost magical. And the question I want to ask and ponder with you is, could we apply that kind of personalization to prevention in healthcare? And indeed, I think we can, and it starts really with the data that we're able to collect now. And really, there's an amazing amount of collecting and analyzing we can do. All your text messages are there, all your tweets, all your Facebook posts can be collected and analyzed. If you track your activity, your step count, your activity level is there. If you track your blood pressure, that's there. On and on and on. And all these digital breadcrumbs are left behind every day. Your GPS phone data can tell us if you went to Starbucks for a latte, at what time you went to Starbucks for a latte. Maybe you had lunch at McDonald's. And we can start to mash these things up on the back end and present to you the opportunity to behave in a more healthy way. And hopefully do it in a motivating way as well. So the data is really powerful. In fact, what we do with it now, and we've accomplished a lot in this space of connected health by measuring feedback loops using objective data, such as all those data points I just mentioned, and feeding it back to people. So I keep track of my step count now via a connected health device, and I always know about where I am. And because I'm motivated to be active, at any time during the day, I can break from my activity of sitting most of the day and do something active. But that's for a small portion of the population who really are motivated to do something with those feedback loops. For the rest, the exciting things we're up to now is applying these various motivational tools. And since you're motivated by things that are different than I'm motivated by, well, we can't use the same one. No one size fits all. But it's our idea that by learning a bit about you, we can predict which ones of these motivators, whether it be social networks, gaming, incentives, coaching, will be powerful for you and bring them into the equation and change your behavior. And applying this kind of tool set that's illustrated here to diseases like hypertension, diabetes, and heart failure, we've had great success. This is what we call phenotypic mapping. This is the other side of the personalized prevention. And then, of course, there's all the genetic information that's coming, the $1,000 genome, all the interesting genetic information. And a lot of what you hear about in this space is a new designer molecule designed to hit a certain kind of leukemia. And of course, if you have that kind of leukemia, it's life-saving, it's wonderful, and it's inspiring. But that's not what I want to talk to you about today. I want to talk to you about chronic illness. And could we use genetic information as a tool to help us predict who might be prone for chronic illness? And that's interesting. And could we bring that into the algorithms and mash it up with the connected health data? And what would that look like? Well, as I've been mentioned, I've been thinking about this, and lo and behold, I came upon an interesting story. This is a fellow called Michael Snyder. He's the chair of genetics at Stanford, a rather impressive fellow. And he's a geneticist. And one day, he was in the kitchen messing around with some DNA. Well, not exactly in the kitchen, but DNA is easy to work with. Some of you may know that. But in his lab, and it wasn't him, of course, it was graduate students. But he did something really powerful and something that scientists have been doing for millennia, which is he decided to experiment on himself. And that's daring. He said, let's sequence my genome and see what we can come up with that I'm at risk for. And that generates something that looks like this. This is called a riskogram. And the way you read this is you have the little lozenges which indicate population level risk. And if there's a black line to the left, that means that the person, in this case Dr. Snyder, is at less risk than the population for a given condition. And if there's a brown line to the right, he's at greater risk. So interestingly enough, he's at less risk for obesity and, it turns out, prostate cancer, which is good to hear. But if you see the one I've circled, diabetes, and the one just below it, hypertriglyceridemia, he's at greater risk for both of those. So now stop and think, what do you do with this kind of information? And I'm going to ask a question. Now, this question is an odd framing, but it's designed to be HIPAA compliant. Who out here among you who does not have diabetes regularly tracks your blood sugar? Good, because if you did, I'd probably recommend you see a therapist. Right, that would be hypochondria. But what would you do if you had this kind of information? So this is what Dr. Snyder did. He employed a connected health intervention. He started tracking his blood sugar and his hemoglobin A1C. Normal fasting blood sugar is about 110, 100. Above 120 is an alarm bell. 150 is full-blown diabetes. Normal A1C is 4 or so. 7 or so is full-blown diabetes. And as you see the graph and the hash marks, he's tracking and nothing's happening for a long time. And then all of a sudden on day 300 or so, look, his sugar bumps. And he's following it, watching himself develop type 2 diabetes, till at day 350, he's got it. A1C of 6.7, fasting blood sugar of 150, and before his eyes, he's developed this disease. Now, again, stop and reflect for a minute, because this is probably the first time in history this curve has been drawn like this. People with diabetes don't have this insight till 5, 10 years later than this event, because you don't feel diabetes. I was watching the New England Patriots last weekend, and I thought, boy, it would be interesting if diabetes and hypertension were like spraining your ankle. Think of how the world would be different, but it's not. They're both silent, so people go along with their life, and all of a sudden they come for a checkup and you've got diabetes and you're starting to get complications. So it's pretty darn interesting to see what happens here. Now, what's going to happen? Is the sugar going to continue to go up? Will it stay level? Will it go flat? Hold on to the thought, because we're going to come back to his story. But I want to share another interesting story with you, and this is a journalist, Tara ParkerPope. She works at the New York Times, and she writes about wellness for them, but she also has a passion for the challenges of weight gain, and she's written a lot about this. She's written about how calories in minus calories out, it's really actually not that simple at all. And calling out research, for instance, that shows that if you gain 10 pounds, many of us, and lose those 10, that when you're back to your previous weight, your body acts like it's starved, and you just desperately want to gain those 10 pounds back again. And I bet a bunch of you can identify with what that feels like. So what's the challenge there? Well, it turns out that if you look at the genome again, there's no fewer than 5. There's probably more. By the way, there's 30 genes now associated with type 2 diabetes. But there's at least 5 interesting buckets of genetics related to obesity. There's this thrifty genotype, which really means you kind of hold on to fat longer. Maybe 50,000 years ago, that was a good trait to have. Not so much when you're surrounded by Big Macs and 20-ounce soda drinks. Or a hyperphagic genotype, which means your set point for feeling full is a little higher than the rest of us, so you're just naturally going to eat more. That's a genetic thing. And you can see on and on they go. And they're all interesting. And wouldn't it be interesting if we knew this about you, say, in utero? Because we're doing genetic analysis now in utero. And when you were young, we could put you on a program that would encourage you to be more active and educate you about eating the right things and educate your family and maybe prevent you from gaining that 10 or 20 pounds to begin with that's just so hard to take off. So Dr. Snyder had a happy ending. He employed another connected health intervention, which was activity monitoring, and he did some dietary interventions, which you see here in the downward slope of the curve, and his type 2 diabetes went away. This isn't so unusual. We do have a number of patients who can tell that part of the story, that if they're disciplined and they lose weight and they improve their activity, they can make their diabetes go away. Not all of them, but many can. But the whole story here is quite remarkable, because chances are great that this whole thing happened within enough time for him to avoid any serious long-term sequela from his brief bit of type 2 diabetes. So that's, again, very interesting. Now, imagine that we could apply this kind of tactic to all of you, to as I say, babies that are being born, to each of us, so that we knew our risk ahead of time, and maybe our health plan program would start to look something like this, where we have your motivational state, which we can measure, we know your connected health data, which we can measure, and we know your genetic risk, and we put that all into an algorithm, and we come up with a unique messaging package for you that's uniquely suited to motivate you to achieve that state of better health. That's pretty exciting. And really, chronic illness is about the choices we make, isn't it? So, in closing, think with me a bit about those movies that we all used to watch. There was actually one recently where there's a time travel. There's a time machine. You go back in time, or the protagonist does, and usually they confront something in their youth that they could do differently, or they have a dilemma. But imagine that, pick a decision that you've made in your life that you really regret. We've all made them. And think about if you could go back in time and you could predict ahead that that decision would have to be made and know the consequences. And I think that will give you a sense of what this new world of personalized prevention can actually be like. So I'm excited about it. I'm happy that you're all here. And I wish you a good afternoon. I'll see you at the cocktail hour. Thank you very much.